Good afternoon. Yeah, this is the right one. So the first slide you know already, I'm going to repeat. In 2014, during the ASCRS, there was a clinical survey, and the surgeons were asked what was their impression regarding ocular surface disease and dry eyes in their pre-op patients. And the result was that less than 20%, this is based on their impression, of cataract surgery patients, they had some ocular surface disease. However, in fact, later on, a serious study was conducted, and the result, it was that more than 60% of patients before cataract surgery, they present some type of ocular surface problem and dry eyes. So in conclusion, there is a surgeon's underestimation and missing opportunities to improve outcomes after. This specifically is for cataract surgery, but later on I'm going to speak about refractive surgery as well, ocular surface. So, and why is so important to assess properly an ocular surface and dry eye disease before any surgery, regardless if it's cataract or laser eye surgery? So the dry eye definitely affect keratometry, topography, wavefront imaging. The tear film irregularities can cause significant aberration. As a result, we have intraocular lens power calculation not accurate, and we have reduced quality after the surgery. And this is the reason. So the total optical power is approximately 60 dioptries. 2/3 of it is in the cornea, 40. And taking consideration that the refractive index from air to tear film is one of the most important, this makes the tear film one of the most critical refractive interface. And that's why we must have a look this before indicate any surgery. This is an example of a 72-year-old lady who was pre-assessed before cataract surgery. And after 5 weeks of dry eye treatment, there was a reassessment of this cornea, and we observed less irregularity in her astigmatism. So decrease of 0.9, almost 1 dioptry of astigmatism, and the axis shifted 11 degrees. So imagine putting a toric lens in these patients, not assessing the ocular surface before. So definitely patient would end up with some prescription or unexpected prescription after the IOL implant. And what about laser eye surgery? In our service, I used to say that we have this care and we have to have a pristine pre-assessment in ocular surface disease, regardless if it's LASIK, PRK, or SMILE. And the literature shows us why, because literature shows us that definitely after the laser eye surgery, patients, they are going to develop anyway dry eyes, especially living here in Middle East. So if we know that they are going to develop dry eyes, some degree of dry eyes, unpredictable, by the way, certainly the first 3 months, long term, we don't know. So we need to minimize these dry eyes after surgery. So the pre-assessment basically start, I think the previous speakers spoke very well about the association from general health condition and ocular surface disease. So normally we have the triaging questions, trying to rule out rosacea, atopic patients, especially autoimmune disease, diabetes, even patients that they are very symptomatic in perimenopause, patients with depression, anxieties, and simply we contraindicate laser eye surgery if the patient has this disease with dry eyes associated. It's important to mention the iatrogenic dry eyes, not all the time that the patient then mentioned the drugs they are taking. We have to rule out all the glaucoma, anti-glaucomatous drops, and also oral anti-allergic drops, antivirals, and this all long list of oral medication that brings dry eyes to the patient. Then it comes the biomicroscopy, where we have to rule out the pterygium, inflammation related to other ocular surface problems. And if the patient has some degree of dry eyes, it's important to differentiate if it's mostly evaporative or mostly aqueous deficiency. Then we can address accordingly. But definitely we start with the triaging, the diagnostic tests, biomicroscopy, and then we differentiate which type predominantly the patient has. Because some case it's worth for us to treat the patient before the surgery, but some case we have to contraindicate. So we start with the questionnaire given to the patient, and then the diagnostic tools. These are my three preferable ones: breakup time, tears molarity test, and fluorescein conjunctival staining, Oxford scale I use. And then based on that, I grade the severity of dry eyes. So here, taking consideration that we have to pile reasons for dry eyes, the environment plays a role, like my previous lecture. I normally, when the patient has grade 2, I try to treat, but if the patient keeps after the treatment of dry eyes, grade 1 and grade 2, I simply contraindicate laser eye surgery. So the top 5 before refractive surgery is listen to your patient and ask the right questions. The questionnaires, they help a lot. The triage is very important to rule out general health condition. We have to use this screening test, so it's very important to have more than one. And then after determining the subtype of dry eyes, we treat accordingly. We target our management plan based on severity level. And when the patient comes back, if there is still some degree of dry eyes that is significant in symptoms and signs, I normally contraindicate laser eye surgery. If not, we just manage expectation, explaining the chronicity of dry eyes and the risks accordingly. Thank you.